Okay, yay, I had success at something technological today. Okay, so I'm sorry for that little hiccup, but I think one of the things that we're all learning with kind of this whole shift into video and telehealth is just patience. I wanted to say that it is a pleasure to be speaking to this group today. And as mentioned, the better part of my time here at Mount Sinai Hospital really is dedicated to the DBS, or the Deep Brain Stimulation Program. And I do feel very fortunate to work with a very skilled team of psychologists, neurologists, psychiatrists, neurosurgery, really, to offer collaborative patient care from a very multi-interdisciplinary perspective. And, today I did want to talk to the group about DBS in both psychiatric and neurological populations. And, with the understanding that the audience here probably has a very broad range of interests and expertise, one of the main questions might be, why is electron DBS of interest to you? Right. So in addition to just wanting to learn something new, I think it's really important to understand that the demand for DBS is actually starting to outpace the availability of DBS providers, and that includes psychologists. And so it's actually a good thing because it means that people are becoming more aware of DBS as a viable treatment option for a variety of medical conditions that historically the medical community really has just run out of options for. And when I use the term the medical community or medical conditions, I use that as an umbrella to include populations typically referred to as neurological or psychiatric. I think that's a whole other conversation. From my perspective, it all ends back at brain behavior relationship. So what is the function of the brain, functional neuroanatomy, brain systems, brain chemistry. And so I'm kind of going to cluster them all together here when I talk about medical populations. So the other reason that this should be important to you, or something that you want to learn about, is that people are living longer. And because of that, they're being diagnosed with disorders at a higher rate than in the past. You're living longer, your body's going to break down. There is a greater demand also for minimally invasive procedures, which essentially is what DBS is, even though it is brain surgery. And a greater number of medical conditions are being explored as candidates for DBS neurosurgical intervention. And so because of all of these factors, there's a very good chance that a fair number of you today might be called on at some point in your careers, in your clinical careers, to be involved with an aspect of the DBS pre-surgical workup or even the post-surgical DBS management. And so that said, the overall goal of my talk is to really provide an overall view of the clinical applications for DBS. We're going to touch a little bit on a lot of different things just so that you can have a really broad perspective of what DBS is and kind of when it might be a good time to suggest it to the patient or to suggest it to the medical team of, hey, I'm following this patient, everything else hasn't worked. Or maybe, hey, we're in the early stage of their diagnosis. Do we want to consider it at this point, as a treatment option? And then we'll talk more specifically, but broadly about the patient populations for which DBS is indicated. And then, of course, what is the role of the psychologist in all of this, right? Because DBS, we think of it as a neurosurgical procedure, but really there is a tremendous team effort, to optimize care, optimize prognosis, and just make sure that the patient is treated as optimally as possible at the end. And then lastly, there should be some time at the end for questions. If not, I might speed it up a little bit just to make sure that there are. Okay.
Christina, sorry to interrupt you. Can
Sure.
you hear me?
I
Do you
can.
mind just designating me as co-host because I can't do anything?
Sure. How do I do that?
In the participant list.
Okay.
Click on the three dots on the right.
You got it. Make a co-host. Okay, I think that worked. Do you have the access that you need?
Not yet. Sorry to interrupt this wonderful talk.
You're totally fine. Okay, so it says you are a co-host.
It looks like Shilpa is a co-host.
Oh, I'm so sorry. I thought that was who was, I'm so sorry, Maria.
Okay, got it. Thank you.
Okay, yeah,
Continue.
no, I'm so sorry. The voices did not come out clearly on my computer. Okay. So, all right. So let's start here with talking a little bit about what exactly is DBS, right? It's initials that's thrown around a lot, for various patient populations. It means deep brain stimulation. And it's basically a neuromodulatory intervention that affects how parts of the brain communicate with each other. It impacts neural pathways. It affects brain chemistry. It works through, essentially implanting a lead, which has electrodes or contacts on it into deep parts of the brain or kind of deep brain regions, deep thalamic nuclei. The part of the brain where these leads are placed is really dependent upon the medical diagnosis. So different medical diagnoses are regulated by different parts of the brain. And so depending on the type of symptom or symptoms that you want to address, you put the lead in the desired place. And we'll talk a little bit about what those places or what those subthalamic or deep brain regions might be. Now, without going too much into the details of brain surgery, because that is not my expertise, kind of a broad understanding is that these electrodes or the contacts, as they're called, that are located on the lead, they send out electrodes or kind of electrical impulses that regulate the abnormalities of the brain. And the stimulation that comes from these targets really can vary in terms of frequency. So how frequently is the stimulation sent out? And then what is the amplitude? Is it high amplitude or low amplitude, high frequency or low frequency? And the type of, and so when a patient, when we're trying to determine the type of stimulation that will work best for the patient, this is something that is done through programming. Okay, so programming is where you adjust the settings or adjust the stimulation parameters. So I'm getting a little ahead of myself, but before we, talk about what programming is, part of this DBS system is having the leads, and most people have one on each side, so one on the left and one on the right. And then there's also a pacemaker-like device that's implanted in the chest. And this pacemaker device basically helps with the adjustment of the stimulation parameters. So we as a team, so medical provider like a neurologist, sometimes the neurosurgeon, sometimes a nurse practitioner, they use a handheld device that at this point in time really is your iPad, or it can be your iPhone. It utilizes a touch screen. And for many of the patients, and we'll talk about this in a little bit, but this is where the neuropsychological assessment and kind of cognitive capacity comes into play. Patients sometimes are able on their own iPhone to do the programming themselves, or to make small modifications. In terms of the programming, you can have the most perfect, MRI that looks the same from patient 1 to patient 2. You can have the neurosurgeon put the lead in the exact place, in these two different people, but they're going to have different responses to the same stimulation program. Part of that is just due to experience, right? We all look different, and our brain also is a little different in terms of the functional pathways. Knowing kind of comorbid medical conditions can affect neural pathways. A history of head trauma can also affect cortical or even subcortical organization. And so these pieces of a person's history means that the program that works for one person that's not necessarily the program that's going to work for another program. So usually it can take about 6 months on average, I would say, for a person to really get an optimal program that is going to help to address their symptoms. So what does a program entail, right? And what are these currents? What are these contacts? What do they do? And so, just a really kind of broad depiction of how the stimulation works. So every lead on it, so kind of looking at the picture on the right side here, There's a pink pathway and there's a purple pathway. And say if we want to target that purple pathway, and so this is kind of like a functional, kind of an image of functional connection. If we want to hit the purple target, we might want to stimulate the first contact. If we stimulate, say, the third or the fourth contact, something that's higher up, we're not going to hit the right pathway. And if we don't hit the right pathway, the patient's not going to get ample relief. On the flip side, if we look over here and we want to hit the pink pathway, hitting the first or the second contact or sending out stimulation on those is not going to help the patient. And so, if you start with programming on the first contact, they might do the catwalk. You might have them walk up and down if they've got a movement disorder and you're looking for a change in their physical response. And you're also asking the patient if they feel any different. They're not going to have any difference. You have them walk the catwalk again, back and forth, observe their behavior, hear their experience on the second contact, and it does nothing. And then boom, you get to the third contact and they say, I feel better. I feel less frigid. My tremor's gone away. And that's something that you can observe as well. So with programming, it's really a way to finesse where the stimulation hits, what contacts are activated, and how frequently and what the amplitude of the stimulation that's sent out looks like. Okay, and all of this really communicates with this pacemaker device. That's really so to speak, the brains of the operation. It provides the information from the handheld device to the leads on the contact. Okay, and then so probably the next question is, okay, of all the places that we could contact, why do we target deep brain regions? So the deep brain regions really do have intimate connections with so many parts of the brain. And, not to go into the specific anatomy here, but this top picture here is really subthalamic nuclei, and it's color coded, and it shows that certain parts of the deeper brain regions do impact cortical or more surface parts of the brain. So by stimulating deep down in the brain, you actually get a very broad effect, both subcortically and also neocortically. And for those of you who do have interest in, well, what are the different targets for all of these different medical conditions? For some of the movement disorders, we look at subthalamic nucleus or the STN or the GPI, the globus pallidus. For things like OCD, we might look at the anterior limb of the internal capsule. Other disorders, we might look at anterior thalamic nucleus. And for other medical disorders that are still considered investigational, the jury is actually still out. But, knowing, if you're not doing DBS, knowing these exact targets is probably not so important at this point. But I mention this because the take-home message is that you can do DBS in various different parts of these deeper brain regions and still get very robust effects in terms of the symptoms that you're trying to regulate. Okay, so this said, we've talked a bit about medical populations and medical indications. In the USA, DBS currently is FDA approved for treatment in Parkinson's disease, essential tremor, dystonia, epilepsy, and OCD. It's considered investigational treatment for Tourette's, depression, chronic pain, headache, Alzheimer's disease, and also addiction. So, again, if you are someone who doesn't work with any of the populations for which DBS currently is FDA approved, yet you do work with some of the populations for which it is currently considered investigational, as the research continues and as we have more and more information data about the efficacy of DBS and the efficacy, kind of ideal target selections, these are populations where DBS might become at some point part of the conversation that you're having in terms of treatment. Okay. And so, just a very quick summary of some of these populations for which DBS is indicated. I think it'll make, in terms of when we get to the part of how is psychology involved or what is the value of psychology, it'll make it make more sense. Excuse me. So in terms of Parkinson's disease, it's, historically known as like the shaking palsy. The onset, average age of onset is the 6th decade of life, but with us being a movement disorder center for excellence, we do see a lot of more unique cases of Parkinson's disease that might have onset in the 20s or the 30s. The kind of classic presentation or the triad of symptoms excuse me, when patients present for initial workup would be tremor, rigidity, bradykinesia. So the tremor in Parkinson's disease, it is a rest tremor. So that means when the patient's hands are at rest, that's what brings the tremor out. When they start to move with the hands, the tremor abates. Rigidity is stiffness. People say that they just feel stiff. They feel very uncomfortable. Usually it starts on one side of the body and then over time progresses to the other side. And then there's bradykinesia, brady meaning slowness, kinesia meaning movement. So they're moving a bit slowly as well. These are three of the main symptoms that can benefit from DBS. Sometimes we will have patients present with like a gait predominant type of Parkinson's disease. DBS does not really do very much for gait symptoms per se. And so, these are things that when a patient comes in, are they eligible? Would they be a good candidate for DBS? These are some of the things that are important for the team to take a look at and to consider. Now, the interesting thing about Parkinson's disease is that, research has really shown that by the time the motor symptoms develop, there is at that point about a 40 to 60% depletion of dopamine. So basically, these are symptoms, or it's a dopaminergic system that has been deteriorating over probably many years before this. And so what we're trying to do now as a research community is take a look at non-motor symptoms of PD. So other things other than things like tremor, rigidity, or slowness of movement that can help us predict if someone has Parkinson's, because if we can basically characterize or identify the disease earlier on and then provide treatment earlier on, it might help with overall prognosis or kind of the level of symptom management that someone can enjoy. There's also kind of flattening of faces, and over time, people have a little bit of a stooped posture. Okay. In terms of two of the other movement disorders with DBS indications, there's dystonia, which can affect different people in different ways. It's a muscle spasm. It's like a pulling of a muscle, a directional pulling. It can start in a single area, like a leg, a neck, an arm. It can also affect larger regions of the body. So what we have here is what we call like a writer's cramp. When people try to write, it's like a pulling and a tightness, and it's very hard for them to write. For other people, there's like a foot dystonia. So when they walk, their foot kicks out, or when they walk, their foot pulls to one side. It can result in falls and tripping. And then for other people, the neck pulls back or the body pulls to the side. So it's very hard and very painful when this muscle cramping, when the contractions, when the pulling happens. It's very painful. And for many people with dystonia, when the pain gets bad, that is one of the reasons why they themselves will present to a DBS center. And then lastly, there's essential tremor, which is a little different from Parkinson's disease. Essential tremor is an action tremor. So when the hands are still and they're not doing anything, there is no tremor. But it's when they start to do something like hold a cup, brush their teeth, hold a fork, put on makeup, that there is significant tremor. And it affects quality of life. It affects their physical, their engagement, and their daily activities. And those are really good DBS candidates as well, when the symptoms get to that point. In terms of the onset, for both dystonia and essential tremor, it can be childhood onset. So, in the practice here, we have seen people with dystonia, when they're 10. We've seen, even a little younger, we've seen people with essential tremor around that same age as well. Sometimes the dystonia symptoms get worse, and sometimes they're static. There's really a lot of variability in terms of kind of the motor symptoms and how they progress and whether they are good candidates for DBS surgery. And then moving right along, last but not least, there's epilepsy and OCD. So epilepsy is really abnormal firing in the brain that causes seizures. And in terms of DBS indications, it's for partial onset seizures with or without secondary generalization that, for the most part, are refractory to 3 or more anti-epileptic medications. So medication does not help to treat the seizures. And so there needs to be something more invasive. There are a couple of DBS systems that are indicated for epilepsy or epilepsy management. And one of the kind of criteria for at least one of the systems is that the patients have to have an average of 6 or more seizures a month. So it's not for the person who has one seizure a year or one seizure every 6 months. These are really patients who are having a lot of seizures, and it's very difficult to control the seizures through normal or traditional medical means. And then there's also obsessive compulsive disorder. It is, something that most of us with the background in psychology are probably fairly familiar with. So it's a psychiatric disorder with a lifetime prevalence of about 2 to 3%. And it's characterized by thoughts and actions, unwanted, intrusive, I should say, thoughts and actions that are also associated with comorbid anxiety and depression, either kind of downstream from just the debilitation and the low quality of life that OCD brings. And sometimes there is just independently occurring anxiety and depression. Onset for this, can be childhood onset. We've seen people where this is developed later in life, or it's been, 70s or 80s. It's kind of like very low grade baseline. And then, it just starts to be harder to control as someone is later in life. For a lot of people with OCD, they can't leave their home. They are really quite paralyzed by their obsessive compulsive symptoms. It's hard for them to hold a job. It's hard for them to maintain friendships. And so, when it becomes to that point where, again, traditional medical therapy does not help, that, the conversation for DBS could be initiated. And so I've kind of hinted at this a little bit, sometimes more specifically stated. So what makes a patient an appropriate DBS candidate? So in terms of movement disorders, specifically Parkinson's disease, DBS historically has actually been saved as a treatment of last resort. And so most of the outcome studies, 15, 20 years out post-surgery, the results are not so great, at least from the cognitive and then also the motor perspective, because we've really been doing surgery, or historically doing surgery, on the very sick patients. And so you're doing surgery on patients where, when we talk about the motor symptoms develop, or we identify them when there's already been about 60% depletion of dopamine. If we waited then another 20 years before we offered these patients DBS as a form of treatment, they probably really don't have a functional dopaminergic system. So you're doing a surgery to help a system that's really almost depleted in its entirety. So there has been a paradigm shift over, we'll say, like the past 10 years, give or take, where instead of using DBS and Parkinson's disease as a treatment of last resort, we're now trying to offer it early on. And early on for some of these people is 4 years into disease. Like once we have confirmed and know for a fact that it is Parkinson's disease, and there are motor symptoms that maybe are well controlled, but there's a lot of medication burden. Or maybe the patient is very sensitive to the medication effects, and even on low doses of Parkinson medication, they've developed a lot of dyskinesia, which is a different kind of involuntary motor movement, a motor symptom that's a side effect of medication. So we offer it as an early line of treatment when we think it could help with medical care, with symptom control, and with improved quality of life. The goal of DBS and any of these movement disorder populations is to basically improve mobility, reduce medication burden, whether it's elimination of medications altogether, rare, but we've seen it, overall reduction in number of times someone takes medication, or overall reduction in the kind of dosing. What is the dose what is the cumulative dose over the course of a day of the medication, overall with the goal of improving quality of life and functional independence. In terms of DBS for epilepsy, as mentioned, the goal is really to reduce seizures when traditional medical therapy, so things like medication, is just not working. And, sometimes there is focal epilepsy, but it's coming from a part of a brain that is responsible for language, that is responsible for memory. And those parts of the brain still work. And if you do a traditional resective procedure, which is kind of basically going in and taking out that entire sick part of the brain, you're going to leave someone with a dense aphasia, or you're going to leave them with a dense amnesia, and you don't want to do that. And so they are not candidates, or so folks where it's coming from the dominant temporal lobe, and their memory is working very well. you don't want to take out those parts of the brain. So DBS surgery might be a really good option for them for treatment of epilepsy. And then lastly, in terms of OCD, it is considered for people who have, essentially treatment-resistant OCD. So they've failed ECT, DBT, CBT, TMS, ERP, medication trials. And again, they're debilitated by their symptoms. And so the overall goal is to reduce obsessions, compulsions, and again, improve quality of life, which, as you can see, is one of the themes here. The DBS surgery is really to just give patients better symptom control, better quality of life. Okay, so we've talked a lot about surgery. We've talked a lot about medical conditions. So probably really critical to this group then is an understanding, well, what is the role of the psychologist in this DBS workup, in this, multidisciplinary team? These are two figures here on the screen, really just to demonstrate that there is so much overlap in terms of brain anatomy with regulation of physical symptoms, cognitive symptoms, psychological symptoms, with psychological symptoms either occurring as a direct effect of the medical diagnosis, so like OCD, for example, or the psychological symptoms could be secondary to a medication effect or to adjustment factors or to a low quality of life. And so I think the psychologist really is in this beautiful and critical position to understand the patient from a more holistic perspective and to try to figure out, what is the main issue, what's a downstream issue, and how do we develop a treatment plan so that we can better understand who the patient is and better care for them and their symptoms. We need to make sure that symptoms really, or the systems are adequately evaluated as part of the surgical workup. We really want to do whatever we can to optimize the patient prognosis. Let me just try to hide the screen here. Okay, so we're going to start with the value of neuropsychology in DBS. At the end of the day, neuropsychologists are psychologists, but with that specialization in cognitive or objective assessment of brain behavior relationships. So the neuropsychological exam or the cognitive assessment is a biomarker that is used to measure the integrity of brain regions. So, as part of a neuropsychological exam, we'll do objective testing to look at attention, memory, language, visual, spatial skills, executive skills. We'll also take a look at quality of life. We'll take a look at psychiatric and psychological symptoms. So, for example, in people with Parkinson's disease, apathy can develop as part of the disease process. Apathy, depending on the severity of it, could have indications downstream in terms of a patient's ability to comply with some of the post-surgical needs. Other people, again, talking about Parkinson's disease, for example, might be on certain medications that can cause them to develop impulse control problems or an ICD, an impulse control disorder. And again, when you see that maybe in combination with things like depression or suicide or anxiety, that could have implications for post-surgical outcome. And so these are the things that are objectively through, objective inventories, objective pencil paper tests. Here's some numbers, tell them back to me. Here's a list of words, say those back to me. Those are things that are really integral to the neuropsychological exam and the pre-DBS workup. So of the many things that can come out of a neuropsychological exam, one of the main things is to determine the current cognitive status and then determine the future cognitive risk. So what does that mean? That means that if we on neuropsychological testing identify that a patient has dementia before surgery, we can be pretty confident that they're going to have dementia after surgery as well. And we know that they're most likely, based on the data that exists, the literature, there's most likely going to be an accelerated rate of post-operative cognitive decline. Now, one of the important things I do want to mention is that DBS does not cause dementia. But if you have a part of the brain that is sick, it's dementing, it is not working well, and you have someone come in and poke and prod at it, you're going to make a part of the brain that's unhappier, very unhappy. So in a sense, because that part of the brain is sick with dementia, it doesn't have resilience. And so it is more prone to get sicker at a faster pace because it lacks resiliency. We are not really seeing most of our patients at this point with dementia because of that paradigm shift. And so if there is dementia, it doesn't mean that someone is no longer a DBS candidate. What we do is we just counsel the patient and more likely their family, where there's like some kind of a healthcare proxy, power of attorney, someone else to facilitate or help with the medical decision making. And we just provide counseling. And, you know, for folks with dementia, they usually have advanced dementia, so they've had it for many years. And often the DBS is offered and wanted for palliative care to help with the family, help the family take care of the patient, or if they're in a nursing home, to help with the staff's ability to manage the patient and to make the patient comfortable. That said, in more of our patients, because of the paradigm shift, and we're offering it earlier on in disease course, the main thing that we're looking here is whether it's kind of this non-amnestic MCI or a minor neurocognitive disorder where, when we think of subcortical regions, and really all of the disorders or the medical disorders, diagnoses that we've just gone through have a subcortical origin. When we think about subcortical regions, we think about attention and processing speed and executive functions. So it is very common for people either from a direct impact of the disease or as a secondary impact of like a medication effect, right? So in epilepsy, even for example, you might be on high doses of like sedating medications to minimize the likelihood that seizures are going to happen, but that's also going to dampen your attention. So those are common profiles. We consider them benign cognitive symptoms. For many people, they improve after surgery, but that does not increase kind of the risk for accelerated cognitive decline after surgery. What we know a little less about are people who have what we call like an amnestic MCI. So these are the folks that we classify as being on a little bit of like a slippery slope. So, they're functional and they're independent and they're ADLs, they're completely independent. Maybe it could be kind of a sign, a suggestion of a conversion to dementia. But we don't know, because historically, any indication of amnesia or a memory problem was a stop point for DBS surgery. And so we don't have outcome data for this amnestic MCI group because this group of people in the past has not been allowed to have surgery. What we're starting to find, though, in our group here is, and I'm involved with one of the studies, we are finding that first off, amnestic MCI is not a stop point. It is just a conversation to have in terms of our counseling patients about the risks and benefits of surgery. But what we are finding, and I think we need larger sample sizes to really say this more strongly, but those with this kind of maybe slippery slope amnestic MCI, especially if they're young and early in the disease course, they are not necessarily at any elevated risk for, real risk, consistent risk for memory loss after surgery, any more so than kind of patients that are treated with traditional medical treatment, which is medications or some of the other surgery, but not brain surgical interventions that do exist. Some of the questions, right? So once we do this neuropsych exam, once we identify if the patient is demented, if there is no dementia, but signs or absence of a memory problem, we give some information of risk assessments, right? So, as I just mentioned, based on the cognitive profile, we will talk to the patient, give them counseling as a team about whether they might be, at risk for taking a cognitive hit, a memory hit after surgery. We sometimes do use the findings, especially in like Parkinson's disease, to help inform target selection. So, with Parkinson's disease, two targets of interest are the STN, the subthalamic nucleus, or the GPI, the globus pallidus. Both of them have, pros, and there are certain reasons or certain motor or medical symptoms that each one might address a little better than the other. Anecdotally, and again, there's no really good research on this, but anecdotally, if someone has some cognitive difficulties or we think they could be at risk for memory loss, we might want to choose one target over the other because from an anatomical perspective, one of the targets is farther away from the cognitive center. The other target is a little closer to the cognitive center. We also want to take a look at whether patients are able excuse me, to cooperate with the the peri, the post-operative demands, the workup, right? So are they apathetic to the point that they will have no motivation to come to the visits? Are they forgetful? Are they going to be able to comply with the device operation, right? So one of the things that we talked about earlier is that in terms of programming, you can do it from an iPad or even your cell phone. And if it's someone who has some trouble with judgment or decision making, or if there is indication of a memory problem, are they going to forget how to use the system, do something wrong, and then mess up all of the programming that's been done? There are also some devices that are, or some systems, I should say, that are rechargeable. And, it's important to take into consideration whether the patient's going to remember to charge the device at night so that it can work the next day. If they might be at risk for forgetting that, or if there's a motivational or apathy issue, again, apathy, not depression related, but really is part of the disease process, we, might want to choose a system that is not rechargeable, that is, that's battery operated, in a different way. We might want to kind of make sure that, especially if someone lives by themselves, that they have appropriate support for someone to help them with these things. We want to make sure the patient can make appropriate decisions. Can they understand the risks of the procedure, the benefits of the procedure? Can they provide informed consent to move forward with brain surgery? Because although it is a minimally invasive surgery, it still is brain surgery. And we also do want to make sure that the patient has realistic expectations for DBS. And what I mean for that is, as a medical community, we might consider a surgery to be a success if there is a 50% reduction, say, just as a kind of a round number, 50% reduction in tremor management, or a 50% reduction in seizure control, or a 50% reduction in depression, in OCD symptoms. But the patient might want to have full resolution of seizures. They might want to have full resolution of all their tremor. They might want to be off all of their medications. And so even if we think, as a medical community, that the surgery is a success, but if the patient wants something very different, they're not going to be happy with the outcome. Their quality of life is not going to improve. Their symptoms, because they might be anxious about this outcome, that anxiety might trigger amplification or exacerbation of some of the symptoms that exist. So we want to make sure that everyone really is on the same page. Talking more to the role of clinical psychology. And here in our center, I'm the neuropsychologist on record, and then Dr. Shannon O'Neill, who may or may not be in the audience here. Hi, Shannon, if you are. She handles more of the heavy weight of the clinical psychological evaluation of these DBS patients. So this is done through clinical intake. It's done through self-report inventories, and it's really done to more comprehensively evaluate some of the psychological symptoms that may be present. So we want to understand if there are any stress moderators. Is there, for a lot of patients, their symptoms worsen during times of stress, whether it's tremor, whether it's seizures, whether it's OCD triggers. So we want to try to take a look and better understand what's in the environment. Do they have coping skills, appropriate coping skills to deal with stress, to deal with some of kind of the stress that's going to inherently be part of kind of the surgical process. We're going to want to take a look at their pain threshold. It is surgery, and, there does come some discomfort with that. Do we think that they'll appropriately utilize their healthcare providers? If there is a problem, do we think that they will follow up? Are they conscientious about their medications, about their medical symptoms? Do they have motivational capacity to follow through on treatment needs? So kind of circling back to the concern about some apathy for some of these patients. It's not volitional, but if people don't have motivation to follow up, we really need to make sure that there's someone with them, caregiver support, to help them along to make sure that their needs are met. We want to further explore if there's a concern for suicide. So a patient has an impulse control problem and maybe some passive suicidal ideation or depression. Those two things together sometimes, can render a very bad outcome. And, potentially a patient not wanting to, but doing self-harm And that's a huge complication, right? So they've got a seizure disorder or a movement disorder, OCD, and now on top of that, they're very injured, if not unfortunately dead after doing this whole workup. So we really want to make sure that they are safe and in a safe place and receiving the types of care that are necessary to keep them stable and healthy, so that they can enjoy the benefits of the outcome of DBS surgery. We also want to take a look at if there's health anxiety. So if people are going to, worry about every little minutia, that can be very exhausting for post-DBS care and management. And again, these are not contraindications for surgery, but things that we just need to take a look at to make sure that the patient is going to have the best outcome possible. And one of the things that really has been a theme is that make sure they have an adequate psychosocial support system. So the presence or absence of a psychosocial support system does not make someone a candidate or prevent them from having surgery. But, if they are alone by themselves, don't drive, don't have easy access to transportation to get to and from visits, we just want to make sure they have VNS, home health care support, make sure that they can do telehealth visits if that's something that can be an option. Or for some people, we, help to facilitate care coordination with social worker support to make sure that they maybe transition into an assisted living facility where they can get that kind of support. The other thing in terms of kind of the role of the psychologist, developing a plan for intervention, giving recommendations to the neurosurgical team is really important. So we want to monitor for change in mood and behavior and quality of life, having a team involved. So here at Mount Sinai, there's a neuropsychologist, a psychologist, psychiatrist, neurosurgeon, neurology, and a social worker. So the patient, as part of the pre-surgical workup, needs to meet with all of us. So you get multiple sets of eyes on you. You have an established relationship. So if there is an issue after surgery, there's a specific person that patient can be triaged to provide a little bit of relief. Plan for intervention. So if we are seeing that there are mood symptoms or there are anxiety symptoms that are really a challenge to the patient, we might recommend some cognitive behavior therapy. Sometimes family behavior medicine sessions are needed, stress management training, and an exploration of whether cognitive remediation or cognitive skills training is something also that could be beneficial to the patient. So in summary, so I know we've talked about a lot of different things, and I'm seeing a lot of what probably are great questions in the chat. So I definitely want to leave enough time to go over those. The take-home message here today is that DBS is a minimally invasive neurosurgical intervention. It has an application to broad patient populations of all ages. We as at the center have seen patients in their teens have DBS surgery, especially for kids with debilitating dystonia. We've also done surgery on people in their 80s who are very healthy and able to tolerate the DBS procedure. The goal of surgery is to provide improved quality of life, to provide symptom reduction. Psychologists really are integral to the success of the surgery and also the patient prognosis. And if, as you're working with patients who have any of these DBS indications or some of these investigational diagnoses where, we are doing surgeries, it's not FDA approved, we're still looking for good targets, it might be worthwhile in a patient with refractory treatments to have the conversation or refer to a DBS center to see if there is DBS utility to help that patient manage their symptoms. And so that is actually the end of my talk. So let me try to, stop sharing. And then I will field any questions that people might have.
Thank you so much, Dr. Palmese, for that wonderful talk. We are in the question and answer period. So if you haven't already, feel free to put your questions into the Q&A and Dr. Palmese will address them one at a time. So are you ready for your first question?
I am.
All right. So this comes from Gregory Hinrichsen. Apologies if I'm mispronouncing your name. And the question is, what about DBS for tardive dyskinesia?
Mm-hmm. So that's a really good question. So for those of you who do not know tardive dyskinesia, that is sometimes a movement that develops secondary to certain medications. So like Abilify is a really big one. And so when Abilify actually became a drug that was being used as the first line of treatment, it started to frustrate a lot of the docs here in the movement disorder center, because we do see a fair number of people who develop tardive, and it doesn't go away necessarily when the medication is stopped. And tardive dyskinesia is one of the main side effects of a couple of different medications, not just Abilify. So we absolutely do we have worked with a lot of patients. We have done DBS surgeries on people with tardive dyskinesia. The targets that we typically use are the same as those for Parkinson's disease, with understanding that the cause of the dyskinesia in someone with tardive is different than the dyskinesia in someone with Parkinson's disease. But it seems like the same brain networks to some extent are involved. So they are definitely good. Those folks are definitely good candidates.
Great. Well, thank you for that. We've got two questions from Joanne Festa. The first one is the comment, thank you for the great talk. And then how long do effects last after DBS?
So that's a good question. So it kind of depends. And what I mean by that, it really depends on whether we are talking about a disease, a medical condition that is degenerative progressive, or if it is a medical condition that is static. So for a medical condition that is neurodegenerative, so probably backtracking a little bit, DBS is not a cure. DBS is used for symptom management. So just working with the movement disorder, specifically Parkinson's disease, because that is a neurodegenerative medical condition. The reason for programming is that as the disease progresses, the parameters, the setting parameters, or the program that might work 1 year after surgery is not the program that's going to work 10 years after surgery. And so on a regular basis, patients will need to be reprogrammed so that the settings can be changed to adjust to the changes in brain function. This said, we have had patients with DBS systems for 10, 15, 20 years, and they're doing pretty okay. Sometimes the battery will burn out and it'll burn out. And so you need to replace the battery. Sometimes over time, improved systems are made. And so sometimes they have an explant, take out the old system and put the new system in. But the purpose really is to adapt the stimulation to the changing needs of the patient so that there is sustained benefit. So it's supposed to be extended or prolonged benefit. In someone with, say, a diagnosis like obsessive compulsive disorder, where it's not neurodegenerative, although we know that the symptoms can get worse over time for a variety of different factors, it's supposed to be sustained benefit over many, many years. We don't have outcome data. OCD fairly relatively recently was approved. So, we're still looking at data from 10, 15, 20, 30 years and so forth out. But the goal is to give sustained relief for an extended amount of time.
Thank you for that answer. And one more from Joanne Festa. Are epilepsy surgeries transitioning to DBS? And if so, are epilepsy neurosurgeons adopting this DBS skill?
That is a very good question. And I don't have the answer to that. Part of that is the DBS indications are so recent. 2018, epilepsy was FDA approved to have DBS. Right now, there are very specific guidelines in terms of which epilepsy populations are eligible for DBS. There are a lot of trials going on to take a look at how long the benefit lasts. And even in terms of the ages that are eligible for DBS and epilepsy, it's changing. So first it was people, I think it was 25, and then it was 18, and now maybe it could be younger. So I think how we conceptualize epilepsy and DBS for epilepsy is so new. And it's still changing, that maybe there will be a paradigm shift, maybe not. Probably it is something that the neurosurgeons are going to have to learn, because it is FDA indicated and there are some really good benefits to it. Whether or not it will phase out completely the typical resective surgery as we see it, probably not. But I think the jury is still out there.
All right. We've got a question from Alan E. Leibter. Instead of electrical stimulation, what about chemical stimulation? For example, infusion of dopamine for Parkinson's.
So if I'm understanding the question correctly, and I might not be, so forgive me for that. But chemical stimulation is really what medication does. And so for like Parkinson's disease, for example, where we have a depletion of dopamine, the medicines over time don't work because the dopaminergic system does not work. And having too much dopamine on board, right? So Sinemet is the drug of choice, or it's one of the main drugs that's recommended for Parkinson's disease because it really boosts your dopamine in the system. That creates a different kind of movement disorder. So too much dopamine, or kind of too much increase in dopamine in the system, so like a medication modulation, causes dyskinesia. Maria, you're still there, right? Okay, sorry.
I'm here, yes.
Okay, and so too much dopamine causes a different unwanted movement. And so over time, the medicine doesn't work, and people have what we call dose failure. So they'll take the medication, even though you're trying to boost them with a lot of dopamine, and it doesn't work. Sometimes the medicine takes longer than it should to kick in. Sometimes, even though you've got this medication or dopamine modification and you're giving them lots of dopamine, the medication sometimes just stops working. And so because medication modulation does not work, and because the boost of dopamine causes a different kind of a motor symptom that for many people is actually more bothersome than the tremor, that is why kind of DBS then is the next best treatment option.
Very interesting. We've got one more question, Dr. Palmese. This comes from Margaret Sewell. I am confused about the non-amnestic MCI slide. It seems to say DBS does not accelerate cognitive decline, but is that the symptom? Is it also progressive over time? And can you clarify that?
So yes, so I think the dementia part was probably not part of your question, because we know if you have like some kind of a dementia due to whatever it might be before surgery, the DBS isn't going to make that go away. In terms of the amnestic and non-amnestic MCI, so traditionally, if someone has non-amnestic symptoms, so they might have a cognitive problem due to inattention. Maybe it's because their medications are up and down and the patient is so inconsistently comfortable, or maybe the attention system is bad because their attention scores on objective testing are bad because they're in so much chronic pain, or because they're on seizure medication. So that's considered completely benign. And so there is no neurodegenerative cognitive issue there. And that is the point of identifying that this is non-amnestic or a benign cognitive profile. From the amnestic MCI, this is where, I think in the next couple of years, we're going to see more and more good studies come out to prove that this also not really an issue. So historically, right? So, and when I say historically, when the surgery's been done in the sicker patients, those who are older, those who are sicker, those who had amnestic MCI ended up converting to dementia at a much more rapid pace. But again, these are sicker patients. And what we're finding now is that if, someone's maybe a little amnestic, but they're young and they're completely resilient, they don't have, so the DBS doesn't stop progression of cognitive symptoms if someone does in fact have the early evolution of a neurodegenerative cognitive disorder co-occurring with the medical condition or the movement disorder, for example. The DBS won't stop it, but what the studies are starting to show is that, historically we've made this classification of demented, non-amnestic MCI, amnestic MCI. The current data are showing that we really don't even need to do that anymore, most likely, because the trajectory or the progression of amnestic MCI in DBS candidates, the trajectory is not necessarily any different than the patients who do not have DBS surgery and just continue with kind of traditional medical therapy. I'm not confirming that necessarily right now, but that is what the data are starting to look at, or what the data is starting to point to.
Thank you so much. And you do have a couple more questions from Joanne Festa and David Dorfman, but because we are at time, I will encourage you all to email Dr. Palmese with any questions. And thank you so much again for this wonderful talk. For everyone, the recording will be available after the talk. And the next grand rounds will be next month, October 7th, same time, and it will be about ADHD and CBT. So we can look forward to that. And thanks everyone for joining. Have a good week.
Thank you so much. Take care.